Hello, everyone. Hello, my name is Akshay Bhavikate. I work as a specialist doctor in general and colorectal surgery, and I'm the colorectal lead and academic for the PrepFRCS course. We will wait for another 5 minutes before we start. Okay, we'll make a slow start. If all of you can open your cameras just at the beginning, and then we can know. I just want to know uh, what is who is who and what is the aim of joining. Um, and please do let me know if you are planning to take the exam. If so, when and what about your preparations? So to begin with, I am Akshay Bhavikate. I am the lead, academic lead in terms of colorectal surgery for FRCS course. Obviously, I think you may all know that this course we have been running for almost a couple of years now, and we always our aim is to achieve 100% result, even though 100% is not possible. We always try and achieve 85 to 90% result. So obviously, we our main difference between the other course and our course is that our course is a 3-month course, and 3 month every weekend, Saturday and Sunday, you would dedicate your time to us, and we dedicate our time to yours. So it's every Saturday and Sunday, 4 to 5 hours each. Sometimes it goes for 6 hours also. Those who are able to attend these things uh, will achieve almost 90% pass rate. The main advantage of the course is, one is the Viva practice. The second one is it is always difficult to find what resources to study, how much to study, and we end up wasting so much time in trying to find different resources. The the overall feedback we have got is that those people who have completely followed our course have not used any other resources at all. They have not read, the cracking, the companion, and all those things, because we cover everything usually. And for the FRCS exam, second part, whatever we generally go through in the 3 months, it is more than enough, and we cover all the fields and subspecialty of in the general surgery. Okay. Okay, so let's begin one by one. Just let me know your name, your specialty, and what is the aim of attending this thing, and also if you're giving the exam. We can. I've got Ravindra. We can start with Ravindra.
Yeah, you can start.
Yeah.
Right. I'm giving my international FRCS exam on 1st of November in Malta.
1st of November, is it?
Yeah.
Now, just now.
Yeah, just now. Next month.
Oh, next month. Okay. Okay. That's fine. Okay. Who's next? Salim. Oh. Okay. Anyone? Ahmad Riyad.
Hi. So I have my next exam, the first attempt, part B, February, with the interest in upper GI surgery.
Okay. Okay.
Yeah.
So you already cleared your part A.
Yeah, I did part A in June, and this is my first attempt part B.
Excellent. Excellent.
Yeah.
Very good. Eugene.
Hi, I have not registered for the exam yet. The purpose is actually for help me to keep the revision and to keep study.
Yeah. And have you given part A or no?
Yeah.
Have you cleared part A?
Yes, I did.
Oh, excellent. Excellent. Very good. Very good. That's the part A is the most difficult part than part B. And try to give exam quickly, like try to give part B as soon as you clear part A, so that you got all the knowledge still there. Otherwise, you sort of tend to forget the basic thing. Emmy.
Hello.
Hello.
I will be having examination in February.
February.
I have cleared part A and I'm doing colorectal.
Oh, excellent. Very good. Very good. Piyush.
Yeah, good evening, Dr. Mani. Good evening.
Hello. Hello.
Yeah, thank you.
Just tell me, what is your specialty, and are you planning to give any exams?
Okay, yeah, I'm a general surgeon. I'm practicing in Saudi Arabia, and the Saudi Council wants us to do an evaluation.
Yes. Okay. I think, yeah. Oh, thank you. Thank you for joining. Yes.
Thank you.
Is there anyone else who's giving exam in February, FRCS Part 2?
Yes. So I've cleared the first part in June,
Oh,
and I'm
excellent.
going in February for the colorectal specialty.
Yeah,
So
excellent.
what's good you have said that, you know, like the idea of like the study materials, because
Yes.
like I've started 10 days ago to look into different materials. I've got confused.
Yeah.
So that's a good idea you have said. Okay.
Yeah, that is so much. Yeah, I can imagine.
Yeah, thank you.
Yeah, excellent. Thank you. Anyone else giving a FRCS part 2 exams? Okay.
Hello?
Yeah.
Yeah, hi.
Hello.
I'm Mutwakkil Salim. Sorry, I have some difficulty in
Okay.
my speaker before, so that's why I couldn't
It's
hear
okay.
you.
Yeah.
Actually, I'm working in Saudi Arabia and I'm practicing vascular surgery,
Okay.
and I have one attempt, international FRCS.
Okay.
That is before COVID, and then we stopped for 3 years. There is no
Okay.
exam for international
Yeah.
FRCS.
Yeah.
Then I find it very hard now to recall
I can
everything.
imagine.
Long
Yeah,
time.
and especially if you're working in vascular surgery, you don't have much exposure to the rest of the systems, which you don't need
Yeah.
actually. But for the exam, yeah, need to.
Supposed to go November for this exam, but I found myself not ready, so I have to
Yeah.
work hard. Yeah.
Okay, no problem. Thank you. Thank you for joining. So we will start in a couple of minutes. I just want to say, like, if you, especially those who are giving the exams in February, obviously we are starting our course in the end of October. So when you're, what do you think is the most important thing that is going to help you clear the FRCS Part 2 exam? Is it the knowledge? Is it the body language? Is it your Viva practice? Or is it the articles or the guidelines which you need to know? What do you think? Which is the first and foremost thing? Yeah, Ahmed?
Yeah, so my impression is like the most important thing. I think all of us, we got the knowledge. So
Yeah.
we know the knowledge, have the pathogenesis management of everything. But what we need, especially to get it from the course, is like what to answer, what to
Yeah.
say, what to tell and what not to tell, what the examiners are expected from our side to say. For example, if you got like a couple of minutes to say like how do you stage or investigate this disease,
Yeah.
not to go through many things and you waste the 2 minutes and you don't give them what they want to get it.
Yeah.
But the point I would just want to ask you, if other colleagues don't mind to waste the time. So it's like, for example, the first session after the orientation one will be like Saturday, Sunday for general surgery.
Yeah.
So in order to make use of the course, to make the best use of the course,
Yeah.
do I have to read the whole section for general surgery from like the Viva FRCS or from the website, or I just came to the course and you will take us through? What is the best thing to do to get the most use of the course?
Yeah, no, that's a good this thing. So I think we have got our own library, and where we have got some sources already there from the general surgery part. So what we generally ask is to go through those important papers and guidelines and things like that. And when you come to the course, as I said, you already have got the knowledge, and then you can just in the Viva. We generally go through most of the books. To be frank, are not up to date. So sometimes many of the books are quite old. So it is very difficult to read the books. So we always advise not to read the books initially. When you are starting out, you need to read the guidelines, the OGS guidelines, the BSG guidelines, the ACPGBI guidelines, the guidelines from the NICE, emergency surgery. So all these sources are already in our library. So once you know these guidelines, you get this basic knowledge what to answer. The management part, as I said, you don't need any more knowledge. You already know how to manage. So as I said, it is the why. And I'm, if I can ask you, how do you think you can improve? What you said is 100% right. It is trying to answer properly. So how do you think you can improve what you said? For example, how do you think, what is the best mode to improve?
Yeah, I think as you mentioned, is like the guidelines. if you go through the guidelines,
Yeah.
and like to have to not to be missing any part of the questions you're going to be asked. For
Yeah.
example, not to get stuck with a question which you don't have any idea to say about it. That's why I would just I haven't figured out the button in the library,
Yeah.
but I will go through. But so you recommend not to get stuck with the books.
Yeah.
That's your
yeah. Yeah.
Okay, that's very helpful. Thanks. Thank you.
So the way, there is no doubt that the FRCS Part 2 exam is a very difficult exam. It is extremely difficult, and you need to dedicate your next 3 months for FRCS Part 2. You need to keep on up-to-date knowledge, and also reading. Whenever you see a patient when you're in the hospital, you need to sort of see, okay, what can I answer, what to do, what is the best situation. And the other part is the practice. The only way to clear the Part 2 exam is by Viva practice. Viva practice with us, Viva practice among your colleagues. When we join the course, most of the times they make sub batches, and they practice Viva. It's all about Viva practice and how you are able to manage a patient in front of you. So these are all real life scenarios. You cannot say, you need to imagine the patient is in front of you, and if there is a question which you have never say, you should never tell it something that you have never done in your life, because all of you are quite experienced surgeons who always act in the interest of the patient. But in the exam, because of the pressure, because of the amount of knowledge you would have gained, because of the guidelines and everything, you end up telling something which you don't do, but in the stress of the exam, you would say something, and that may come across as it is unsafe. So always imagine the patient is in front of you and what you are going to do for the patient. And the patient as a whole is your responsibility. If the patient has got a cardiovascular problem, it is still your responsibility. If the patient has got a respiratory problem, it is still your responsibility. If the patient cannot be discharged, it is still your responsibility. It is your responsibility to sort out the patient. As far as the exam is concerned, you can always say, I will take a cardiology input, but you need to know the probable help or the probable advice from the cardiology would be 1, 2, 3, 4, 5, or the probable this thing from the oncology would be, I think this patient may need a chemotherapy and things like that. So you need to treat the patient as a whole, and you have to take the patient as a complete responsibility. Obviously, in practice, we generally see the patient, and there's anything, we refer the patient to medics, we refer the patient to ITU team, we refer the patient to anesthetist. But you need to know why you are referring the patient to anesthesia. Hey, okay, I'm going to refer the patient to anesthesia and stop. Then the examiner will say, look, the anesthetists are there to anesthetize the patient. They will anesthetize everyone. Are you happy to proceed? How are you going to have the discussion? So always treat the patient as a whole, as far as the exam is concerned. One of the main advantage of our course, actually, like, to be very frank, when I gave the exam, I gave the exam in 2021. At that time, because of the COVID and all those things, we didn't have real patients and all. I am from colorectal. My 80% of the exam was colorectal, and very few was from the, like, I didn't add any scenarios from the breast and things like that. But over the period of last 2 years, what we have noticed is, it is people from colorectal have been asked about breast, especially in the long case general surgery clinical viva, and it is not just the basic knowledge. They want to know what are you going to do, what chemotherapy the patient may need, what is the best safe thing to do, whether this patient need a mastectomy or not. So it is like that. And then there was another case where there was a case of shoulder sarcoma or a retroperitoneal sarcoma. So, and then there was a case of where someone had a case of a renal transplant, and the patient had come with abdominal pain. So they're mixing quite a lot, and it is quite difficult to get all the knowledge. So one of the advantage of our course is we cover everything over the period of next 3 months. In the breast part, we cover what is required for the non-breast surgeons and what is required for the breast surgeons. The same thing applies for the HPV transplant and all. So it is more and more important that you need to get a general, a bit, not only basic, a bit of advanced idea about everything, about all the specialty, and you need to know quite a lot about your own specialty. And just one more thing is, guidelines is important. There is a difference between guidelines and papers. Papers, obviously, is the recent studies that has happened and that has been ongoing, that can change the patient management. But guidelines are already there. So guidelines will give you quite a lot of marks. So for example, you can say if there is a hernia, and if the examiner asks, oh, why do you think so? Does this patient require the open hernia or a lap hernia? Does it require a local or GA? You can always say, well, according to the NICE guidelines. So once you say the guidelines, you are already getting extra marks. The papers and articles is almost like a, you've already cleared the station. You've already done very well. The examiner is generally out of all the question he has asked. So then he will go on to say, okay, are you aware of any recent landmark studies that has happened in your own specialty? What do you think that, and things like that. So you need to know about the guidelines. The articles is different. If there is any breast surgeons here, or if you are giving exam for the breast, it is completely different. You people should know all the recent guidelines, recent articles, recent this thing, because one whole station will be about the articles and their discussion and the trials, which again we generally cover in our exams. Yeah. Ahmed?
Yeah, so the good example you just tell about the hernia, I was just about to ask about a question about the same example or more relevant examples.
Yeah.
So, for example, if I am in the exam and they ask me like a patient is coming with a unilateral inguinal hernia, okay? So how do you treat the patient? So he went through the anatomy things and all stuff, and we ended up the management. So the guidelines is say open or unilateral primary hernia, you do it open. If it's bilateral recurrent, you do it laparoscopic. What they want to expect me to answer, for example, if myself I would just any primary unilateral hernia, I would start it as laparoscopic, for example. Shall I do what I do in practice first and then clarify with the guidelines? If, for example, if I do laparoscopic for unilateral, so I said I will offer this patient a laparoscopic hernia repair as a tip, for example, but then I said, but the guidelines said to do it as a unilateral primary, to do it as an open, and if it's bilateral recurrent, to do it laparoscopically. But myself, I will do it this way. Or shall I answer it the other way? I will say like, no, I will do it as, according to the guidelines, I will do it as open, and if it's bilateral recurrent, I do it laparoscopically. Which one of the two ways shall I go? And the same for any other examples. You got my point.
Yeah, exactly, exactly.
Yeah, thank you.
So there are two things. One is you always say that you want to make a shared decision with the patient. So you provide options for the patient. You don't use rather than generally once the clinical scenario is over, they're going to the question will be, okay, now, okay, doctor, what are you going to do? That's the question. So you would say, well, the options are a laparoscopy or a open repair. But in my practice, I generally do laparoscopy, but I would discuss with the patient, and I'm aware of the NICE guidelines, but I would still discuss with the patient and see whatever is required under this thing. So you provide. So basically, you provide options rather than telling the patient. You provide options, and then they may ask, okay, how are you going to consent the patient? And the patient may ask, okay, I want open, I want laparoscopy, what is the difference, and things like that. Yeah.
Okay, fine. So I would say what I'm doing in practice, but I justify
Yeah.
that maybe the guidelines said do it open, but I do in
Exactly.
practice laparoscopic, but
Yeah.
I know the guidelines is saying
Yeah.
what 1 and 2 and 3.
Yeah.
Yeah.
It is
Okay.
almost like the examiners will like you. Generally, they like when you share your own personal experience. For example, there's a case of leak or this thing. Some people will do CT scan immediately. Some people will take the patient for laparoscopy immediately and everything. You can always say, well, in my practice, I generally I have very low threshold to take the patient for re-laparoscopy after if there is any evidence of leak. So I generally take the patient and this thing, something like that. So you can always share your own experience, and obviously all of us learn from our own experience. And sometimes the other part is to try and read the examiners. Some examiners want to guide you. Some examiner might not like your answer. Then you can quickly change it. Oh yes, I agree. The CT would be this thing, but in my practice, I generally do, yeah. But CT is also fine, or something like that. So you need to little bit study the examiner also.
Yeah, good.
But always share your experience, and always think that it is not a MRCS exam; it is an FRCS exam. But the questions are MRCS level, not the FRCS level. Okay, in an inguinal hernia station, the questions will be: how do you examine a hernia? How do you differentiate a direct and indirect hernia? What are the tests what do you do? What physical test do you do to differentiate a femoral hernia and an inguinal hernia? Can you do this thing? So this is the level of questions. Once you cross these part and you go to the management, then the part of laparoscopy or open or everything will come. So yeah, the basics is very important. Okay, let's.
So just a quick thing, actually.
Yeah.
This is Ahmed.
Yes.
So discussing the hernia remind me of one thing. Last week I attended a laparoscopic hernia course, and the lead of the course insisted about that the new guideline is to offer the patient laparoscopic, and this is the guideline, and this is the guideline. I left the course. The next day, I've searched in the NICE guideline. He mentioned specifically NICE guideline, and I found out that the guideline is not changed since 2004.
Yeah.
How can I manage to find out the most recent guideline that keeps saying about this?
Yeah, exactly. So this is again a very good question. The thing about is with your consultants, obviously when you are in the hospital with your consultant, there is a this thing to, okay, let me have a Viva discussion with my consultant. Let me have a Viva discussion with this thing. The problem is most of the consultants have not given the exam recently. They have given the exam quite long time back ago. Okay, at that time, the way they do the exam, I don't know, might be different, or they end up putting stress and things like that. The exam right now, it is not like that at all. The people are quite friendly compared to before that. So I would say just stick with whatever the NICE guidelines is, because you need to remember that the examiners, or majority of the time, they're all old timers. They are quite rarely are up to date with the new guidelines and things like that. But you can search the NICE guidelines. Obviously, if it is updated, you can quote it, but do not quote just because someone says that that's the guidelines, unless you actually know, is the guidelines real, or is there any evidence behind that. So I would say just go through the NICE website. Whatever it is there, you can say it is the guidelines. So just be careful when you're trying to do Viva with your own consultants, because sometimes they're obviously number one, they're not actual examiners, and they actually don't know how what is the way to examine. And sometimes, majority of the times, they put you under undue stress, and you come back with a much lower confidence, which is actually not required, to be frank. Okay, so let's yeah. So we'll do some let's do some Viva. So we'll start with Ravindra. He's giving the exam just now. Amy.
I want to try the Viva.
Let me start with Ravindra. Then I'll come back with I'll come back to you. Ravindra is giving the exam. I'll just finish him. Okay. Okay, Ravindra. So, Amy, you can. I'm going to ask you after this Viva. I'm going to ask you to give feedback to him. Okay, feedback about how we answered and all. Okay. Let me start the timer also. Again, Ravindra, I know you are giving the exam quite soon, so please don't. Are you happy to answer, or you don't want to answer?
Yeah.
It's fine.
I'll take a chance. No problem.
Yeah. So just let me know. I don't want you to lose any confidence and then something like that. Okay. Okay. So let's start. So Ravindra, you're the so we'll do it as a short case, which is like a 10 minute, and we'll see how it goes. Okay. So you are the general surgery consultant on call. There is a patient in ED. He's 42-year-old man. He has come back with severe abdominal pain, nausea, and vomiting. The ED wants your review. You are the general surgical consultant on call. It's Saturday afternoon.
Yeah, I'll just go to the ED and see the patient, and I'll start seeing the patient as per this protocol. Simultaneously, I'll assess the patient and resuscitate the patient. I'll assess for A to E, airway, breathing, circulation, disability, and exposure. I'll check the airways patent. Patient is breathing normally. Air entry is equal on both sides lungs. There are no abnormal signs or no absent air entry. Simultaneously, I'll take a 2 wide bore cannulas and start with the IV fluid resuscitation. Just check his blood pressure, heart rate. And after the end of this assessment, I'll just see the patient now is stable or unstable patient. If I'm finding this, now I'm finding this is a stable patient, I'll take a focus history from the patient. I'll ask about this complaint when particularly he has a complaint.
How can you, is there any scoring where you can get an idea whether this patient is stable or not?
New score can be used.
Can you tell me the components of new score?
Is heart rate, systolic blood pressure, and oxygen saturation.
Anything else?
Age of the patient.
No. Anything else? Okay, that's one. Just make a note. You should just read about new score. And what do you understand by the time I will say, well, the patient new score is 5? What does it mean?
That means it's a critical unstable patient. I have to alert the ITU, ITU of the hospital, high dependence unit.
Good, very good. Okay, and what do you understand if I say new score is 2?
It's a stable patient. We can go ahead with a planned treatment for.
Good. No need. Okay. Okay, that's fine. So you have done the CREST protocol. The patient is now stable. Is using 2. Proceed.
Yeah, I'll take the focus history of the patient. I'll ask about the onset, duration, progress of this pain, when the pain is started, how it is progressing. It's on and off or continuous. Is there any radiation of the pain? Is there any past attacks of similar type of pain? And is there any particular relieving aggravating factors for this pain? And then the patient has simultaneously vomiting also, nausea and vomiting also. Then I'll ask about the character of the vomiting, whether it is bilious, non-bilious, he's omitting any food particles, is there any blood or is the feculent smelling omitting is there? And what is the association of this omitting or pain, how it is coming after pain or before pain? And then I asked the patient any past surgical or medical history, and then I asked his social history, is any intake of alcohol, smoking.
Yeah.
Since he's a 42-year-old, since I'll prefer to ask him the red flag signs like in the form of weight loss, anorexia, rectal bleeding, or any GI malignancies or IBD history in the family.
Yeah.
And
What are the various differential diagnoses you can think of in a 42-year-old man? Epigastric pain, nausea, vomiting.
In a 42-year-old man with these symptoms, my first suspicion is any acid peptic disease in the form of peptic ulcer, gastritis,
Yeah.
or any duodenal ulcer,
Yeah.
pancreatitis,
Yeah.
pancreatitis, or any hepatic causes. And simultaneously, I'll think about some medical causes in this patient,
Okay.
like
That's good.
myocardial or.
Okay, that's fine. So the patient says he's been having epigastric pain for last 3 days. The pain is radiating to the back. He's been having vomiting continuously for last 2 days, and he's known to have alcohol, and he's a smoker as well. He has got a past medical history of cardiac bypass surgery done, and he's on aspirin and clopidogrel as well at the moment. Okay. And to exam.
Yeah, I like to examine the patient with general examination. I see for the pallor icterus, cyanosis, adenopathy, any supraclavicular fullness in this patient, and I look at the abdomen whether it is distended in particular portion is a uniform distension or particular portion is distended, and I'll proceed the palpation of the patient. I'll check for the signs of peritoneism. Is there any guarding compartment of the abdomen? I'll check for his hernial orifices, and then I'll proceed with the rectal examination for this.
Okay, that's fine. On examination, your patient is quite tender in the epigastric region, and and the patient is complaining of the pain in the back as well. And rest of the examination is okay. And the blood test have come back. The white cell count is 15. CRP is 120. Is amylase is serum amylase is 1000, and liver function test is slightly abnormal. Yeah.
If I see the history and latest blood picture, blood biochemistry of this patient, and I'll follow the revised Atlanta score, and I label it as acute pancreatitis, maybe induced because of alcohol ingestion, because the patient has classical history and amylase is 3 times than the normal.
Okay.
And then anyway, I have just resuscitated the patient as per in the beginning of this thing. I'll check I'll check how he's responding to the fluid resuscitation. I'll give the analgesic to the patient and revise his I'll check how he's responding now. How is the blood pressure? How is the pen score? Then I'll just. I want to stratify.
So I am the nurse taking care of the patient. Okay, you are in the bay. I am the nurse taking care of the patient. Give me the instruction. What do you want me to do for the patient? So you have got the blood test, and you think the patient is having pancreatitis. Give me instructions. What do you want me to do?
Since patient is nauseating but not vomiting, if the patient is able to, patient is feeling hungry, thirsty, I'll just encourage the oral feed for this patient. I'll resuscitate with the IV fluids to maintain the adequate urine output. I'll see I'll check the pervasive catheter is in place and the patient has got adequate urine output. I'll give the adequate analgesia to this patient and adequate analgesia to the patient, and I'll just check the progress of the patient, how will improve in next hours.
Do you need to do any scoring?
Yeah, this is alcoholic pancreatitis. I'll prefer to do the Glasgow Glasgow MS scoring for this patient, and but his CRP is 120. You said. I'll prefer to shift him to the ITU for the further management of the patient, and I'll do the bicep scoring for this same patient.
So what scoring do you do? Are you going to do all the scoring, the Glasgow Limerick score as well as bicep score? What score are you going to do?
In this alcohol-induced pancreatitis, I'll prefer the Glasgow MS score.
Okay. It can be. Can it be gallstone-induced pancreatitis as well?
Yeah, it might be because we have not done any radiological imaging for this patient.
Yeah. And can it be a duodenal perforation?
Yeah, there are higher chances, but if this patient is not fitting in the revised Atlanta category, I'll definitely think about the other differential diagnosis of this patient, and I must have I definitely I'd like to do the chest X-ray to rule out the peritoneum.
Good, very good. Do you think this patient needs a CT?
As per recent guidelines, I don't think so. Patient requires CT scan.
Okay. What is the indication for CT?
If there is a diagnosis in doubt, if the patient has got a complication of pancreatitis, to rule out the complication of pancreatitis, we require CT scan, contrast enhanced CT scan. And patient not responding to the medical management, initial medical management.
Okay. So the patient has gone to ITU, and today is day 2. You have done an ultrasound scan, which is showing some evidence of gallstones. The patient has gone to ITU, and today you get a call from the ITU consultant telling the patient is having he's having difficulty in breathing. His NEWS score has gone very high. His respiratory rate is now reached 30, and his abdomen is distended.
I'll go to ITU again. I'll resuscitate, assess and resuscitate the patient as per this protocol. Again, I'll check his as per protocol. I'll check from A to E and.
Okay. You have done all the CRISP assessment.
Yeah, and with this clinical picture, now I'm concerned whether the patient is, as per my expectation, patient is not responding. I'm expecting some complication of pancreatitis. He's breathless. He might have developed pleural effusion. I'll advise to get the chest X-ray, a fresh blood set of investigation, chest X-ray, ABG for this patient. And I advise the CT scan of the patient, which will be contrast enhanced.
Why do you want the CT? What are you suspecting?
There are two. First thing, patient has become suddenly unwell after 2 days of the initial course. I'll suspect whether patient is developing pancreatic necrosis or there is peripancreatic fluid collections or any infection is setting in.
Today is the day. It is just day 3. Do you think pancreatic necrosis can happen in day 3?
Yeah, it is possible.
Is it possible? Okay. So you've done the scan. The scan is showing that patient is having ileus, and he has got fluid within the abdomen as well, ascites, and his chest X-ray or a CT chest is showing some bilateral pleural effusion also.
I'll just go through the CT scan picture. I'll just consult with a radiologist who has reported these films, and I'll just discuss with him whether they can make out whether it is the fluid is origin from the pancreas or any other viscous perforation we have missed initially, or and if there is in the view of that free fluid, I'm just doubting about whether patient has developed pancreatic ascites.
Yeah. So the radiologist have told that there is no evidence of a bowel perforation. All the small bowel and the small bowel is all dilated. It's got some ascites, and the pancreas is all stranding, and pancreas is swollen as well.
I'll definitely like to involve the IR team for aspirate that fluid and check for the amylase level of pancreatic ascitic fluid, and then label with the pancreatic ascites, and uh, then I'll continue with the same medical line of treatment.
Yeah. Okay. Okay. That's fine, Ravindra. That's fine. Okay, we'll stop it here. Yeah. Okay. Don't worry. Are you okay? Yeah. Yeah. Amy, what do you think?
Uh, First of all, I think he did very well. In the A&E, he immediately say that he will use the CRIPS protocol and assess the patient. And he is also able to give the correct differential diagnosis. And to be honest, he can make the diagnosis very early with make the diagnosis of acute pancreatitis. And but I think I'm not quite sure whether I think he missed your hint that there is deranged liver function, and so he think it is an alcoholic pancreatitis, and thus he I think he missed that, so he didn't ask about the ultrasound.
Yeah.
That's what I think. Yeah. But in general, I think he did very well, especially at the beginning. He said about the CRIPS protocol, everything is
Ravindra, I think as I mentioned, you did quite well. So the thing is, always start with your concern. So as soon as you get a call, so you are already a consultant, okay? So as soon as you get a call from A&E, you and while you're walking into the A&E, your differential diagnosis almost goes in your mind. So you need to tell, okay, so my first concern, or I'm concerned about whether DU perforation, pancreatitis, or this thing.
Mention these things.
Sorry?
Should we mention such things on my way to A&E? I'm concerned. These diagnoses are running in my mind, and there is, and then I follow the CRISP protocol.
So you should say, well, my top concerns or my main concerns in these patients are I'm worrying about pancreatitis or DU perforation or any medical issues. So that's fine. So you already know what you are trying, and the examiner also knows. Okay, you already know what you are trying and what you're going down for. So as soon as the scenario starts, you should tell my concerns are. This applies to everyone. This applies to all the clinical this thing. You are seeing a patient. So you are seeing a patient is a 42-year-old patient for a rectal bleed. Is in your clinic. Can you start the scenario, or they say what can you start? You can always say, well, he is a young patient. My first concern in this patient would be a benign causes, and then there's always a possibility of a malignant cause. So this will show the examiner your overall thought process. Okay, and then you go down, you do the CRISP protocol, and you can say CRISP and new score. New score is going to save you. Okay, new score. Once you say new score, you don't have to specifically tell that I'll check the blood pressure, the pulse rate, this thing, the respiratory rate, the oxygen, and everything. So I would like to know the new score, and that will give me an idea. Yes, and the examiner say, okay, the new score is 5, and which you said. So immediately you say that, okay, new score is 5. I'm quite worried about the patient. Let me first stabilize the patient with oxygen and blah blah blah. Okay, so if the new score is 2, then it's good. So it looks like the patient is stable. I would get more history, and you did the history well, and the examination part well. Scoring, always be very specific in what you're telling. Stick to one score, irrespective of whatever score you want. Stick to one score. Know every component of that score, and know what is the importance of that score. Why are you doing the score? And if you are going to refer every patient to ITU and this thing, then what is the use of scoring? Yeah.
Okay.
So you should know, or you can clearly say, well, there are many scoring systems, but I personally don't use it regularly in my clinical day-to-day case. I go by patient to patient. If this patient new score is 5, irrespective of it, whatever the score is, I'm going to involve the ITU. Or if you are really confident about the scoring, do mention that scoring. So if you're really confident about something, mention it, mention the components. That is the chance where you can show your knowledge to the examiner. Okay. And then, but otherwise, rest of things, then we went to the ITU. The ITU, you did well. Slightly you're off. So again, what were your main concern? Why do you want to? So what do you think it's happening? The patient is in day 2, abdominal distension, difficulty in breathing, CT shows paralytic ileus, ascites. Yeah.
Yeah, abdominal compartment
Yeah.
syndrome.
Yeah. You didn't mention.
Yeah.
Well, so you know it. Yeah.
Okay.
Immediately you should say, oh, well, I'm quite worried about abdominal compartment syndrome in this patient. So first thing I would like to do is measure the abdominal compartment pressure, make sure that it is well below. I'll speak with anesthetist, and then because of this thing, because the scenario might be test your knowledge about abdominal compartment syndrome also. Okay. Yeah. So otherwise you did quite well. The other important thing, I want to mention is I did tell you that I am the nurse. I am in your bay. I asked you to give me instructions. Okay. So what I'm testing is how specific you are in giving me instructions. You cannot say I'm going to start IV fluid. You should say I will start 1 liter of Hartmann's solution to be run over 4 to 6 hours, and make sure the patient has got a catheter. I'll ask you to monitor the urine output. Analgesia wise, I will make sure the patient has got whatever, morphine or this thing, or if you want to start a PCA, you're going to start a PCA. And the nutrition wise, right now, I'm not extremely worried about nutrition. I'm going to get the patient on sips of water, and then I'm going to ensure the patient is comfortable. And I'm going to tell the nurse to do 4-hourly observation to ensure to see if there's any changes. So this is the specific instructions. Yeah, that and they want to know whether you want to give antibiotics or not. Again, you didn't mention. Yeah, the scan was the scan you answered well. So when they ask you in general, so when they ask you, okay, what are you going to do? You need to say just be 1, 2, 3, 4, 5, 6, 7, and the instruction should be as if you are giving an instruction to an F1. Okay. If you start, if you ask an F1 to start, can you start fluids? Say, just imagine he is a junior doctor on day 1 of his job, and you ask a patient, oh, can you please start him on fluids? He will not know. So imagine you are giving instruction to an F1, and so what specific instructions? So these are the small points that are going to improve this thing. But overall, I think you did quite well. Okay. Yeah. Any questions? Anything? So this is the general process. Okay. First is the diagnosis. Then what are you going to do with the diagnosis? And once you reach the diagnosis and basic management, patient will develop a complication. And then what are you going to do with the complication? That's how the usual overall scenario goes. There is all the scenario goes in the same way. Okay. So there is never a scenario. Okay, the patient is all fine. You can go home and the patient went home. Okay, there is never a scenario. Yeah, you do something. You arrive at a diagnosis. You start the basic management of that diagnosis, and the patient will develop some complication. And how are you able to recognize that complication? Or are you able to manage that complication? That's all. So again, so if you have already treated that complication also, then comes a chance where what is the new guidelines and what is the studies and in general where you can get more marks. Yeah. Yeah. Pius?
Yeah, thank you very much.
No problem.
I have a question.
Yeah.
My question is, if you are called to the emergency room, is it on the survey? For example, a patient presents with, acute inflammation of the breast. Maybe it has a breast abscess.
Okay.
You are called to the ER. Do you need to go through airway, breathing, circulation, and then down to everything? I just need to be clear on this.
Yes.
Or I can go and ask, I can see the patient and begin to, go straight and begin to ask about the history of the problem.
So from the exam point of view, there are two ways you can answer. It depends on the history. Sometimes if the history says patient is having acute abdominal pain and nausea and vomiting, well, just to be safe, you can always be this thing that I'm quite worried about the patient, and then that is where the new score comes. I'm going to assess the patient new score. If the patient new score is 2, that means patient does not need resuscitation. Patient is fairly stable. If the patient new score is high, then the patient needs some kind of resuscitation. Yeah.
Okay.
So, but again, to be on the safer side, you can always assume the patient is a bit sick. You don't want to be in a situation where you start taking the history, and the examiner will say, oh well, you didn't do crisp, or patient is having a pulse rate of 130 or 150, something like that, and then sort of you'll be this thing. But you can always start with the crisp, and the examiner will say, no, patient is stable, you start with the history, something like that. Okay. So always error on the side of things. Yeah.
Yeah. Thank you.
And generally in the exam, when you say, oh, I'm going to approach a patient with a crisp protocol with airway with A to E, most of the time the examiners, unless they want to assess what is whether you know A to E or not, the examiner will say, okay, the crisp is done, let's move on to the history or something like that. Usually, yeah. Ahmad?
So I will just go through the scenario which you give, and I have just a couple of questions. So Ravindra, you did very well. And you have a good approach, really, which I like it. Okay, so the first thing you mentioned in the user score, you mentioned to him, the consultant said to you, user score is 5. Shall I ask the parameters of the user score? Just for example, if he said like the patient got a high temperature, so that's mean and low, and the systolic blood pressure is low, so that's fall under the septic 6. So I would say, shall I say the patient, I'll ask the nurses to initiate, I want a urinary caster, antibiotics, fluids, and I want to start IV antibiotics because this may be sepsis.
Yeah.
That's the first thing to ask. The second thing, you did give them during the history, you said the patient has a cardiac history before.
Yeah.
So should I ask the nurse to do troponins levels and to do an ECG as well?
Yeah.
The third thing, when you ask that the patient, you need to do a CT scan, the CT scan because he had a respiratory problem and an abdominal is distended. So because the CT scan, shall I before, when he said, shall I tell him before that I'm suspecting it could be a pleural effusion, as Ravindra said, like pancreatic ascites, and also I have to check the albumin level, and because like the respiratory complication could be ARDS, which I have to exclude, and also the abdominal distension, it could be abdominal compulsory syndrome, but I have to check the albumin. His albumin is low. That could be a mesenteric vein thrombosis. It could be a bowel ischemia because dilated bowels on the CT scan. There's a bit of ileus. I have to rule out ischemia. Shall I go through this and tell him just all my differentials, or just stick to the point like Ravindra made?
So generally,
thank you.
The first 2 points you made was good. So you need to see whether the new score, and you can always ask. I want to know whether the patient has got temperature or not. If the patient has got temperature with a pulse rate and this thing, I'll be suspecting sepsis, and I want to start sepsis protocol. That is so. When you approach like this, you sort of cover all the bases, and you don't this thing for any room. So that is quite good. The other thing is you can always suspect one by one. Sometimes if you give too many differential diagnoses, it will be quite confusing for the examiners. The other thing is you can see, obviously, once if the patient has not had a CT after day 2, if the patient is not doing well, we will get a CT. So you can always say that I'm going to assess the patient, and the patient I will be getting his CT scan. Then you can say I'm suspecting. Then they will ask, oh, what is the reason for getting the CT? You can say all the things you mentioned, and then I'm going to assess the albumin and everything. But I think in this scenario, the scan is most important. That is going to give a diagnosis. So you can tell albumin, but I would say first scan first, and then albumin and everything. So try to arrive at a diagnosis, or try to tell the most important investigation first, and then you can arrive, and then you can tell all the other contributory things. Yeah. So
Thanks.
You can sort of play in the exam. If you know something a lot, you can sort of draw the examiner towards you, and then you can showcase your knowledge. And but if you don't know something, you can always avoid mentioning that. The worst thing is telling that I'm going to assess the patient on a Glasgow-Limray score. The next question is, can you tell me the components of Glasgow-Limray? Oh, I don't know. So that's the worst thing. You should avoid.
Don't dig a hole for yourself.
Yeah, exactly. Please avoid the situation completely. Even if you don't mention any scoring, it's absolutely fine. Yeah.
Yeah,
Okay.
thanks.
That's good. Okay, let's Amy. You are quite eager to start.
I'm fine. Anyone who wants to try?
No, it's okay. We'll start. You are colorectal, yeah?
Yep.
Okay. Okay, so you got a 55-year-old patient. You're seeing him in a clinic. We will do like a 15-minute scenario. So you are in the clinic, and you have been referred a 55-year-old patient with change in bowel habit and bleeding per rectum and a fit of 20.
Sorry, I missed the last sentence. Is it
Bleeding per rectum,
Yep.
change in bowel habits,
Yep.
and fit test.
Yep.
Yeah, fit test of 20.
Okay.
Yeah.
So in this patient with a change of bowel habit and a fit test of 20, I would definitely worry about colorectal cancer. So I will assess this patient, take a focus history, and also do a detailed physical examination. In the focus history, I will mainly focus on the red flag sign. Especially, I will ask about any PR bleeding, any abdominal pain. How bad is the change in the bowel habit? Any intestinal obstruction symptoms, and I will also ask about any recent constitutional symptoms like weight loss, loss in appetite, and I will ask about some risk factors for colorectal cancer, especially whether there is any family history of colorectal cancer. And I will also, from the history, assess the performance status by asking about the medical history, surgical history, any lower GI workup done before, and well as asking about the any medication that he's taking. And in the physical examination, I will check for any anemia, color, and feel for the abdomen for any.
Also important. We'll go to the physical exam in a minute. So this patient has got change in bowel habits for last 3 months and bleeding per rectum. What are the various differential diagnoses you can think of, and how are you going to narrow the diagnosis based on the history?
So I will ask. Actually, the most important diagnosis I need to rule out is colorectal cancer. But a patient having PPR bleeding, I would also like to rule out a rectal cause of bleeding. For example, hemorrhoid, anal fissure, and also maybe fistula. So in the history, I'm sorry that I also need to include asking about any anal pain, for example, any constipation, any prolapse hemorrhoid, etc.
Yeah. Okay. And what is the importance of a family history? So if I say the patient's father was diagnosed with a colorectal cancer at 60 years, is it anything significant?
So if only one, because according to the ACP GBI guideline, if only one family history diagnosed like 60 years old, but no other relatives, I don't think it's very worrying at this moment. However, if there are like 3 relatives or one of the relatives diagnosed before the age of 50, then I would worry.
So what would be the what will the guidelines say if he has had a father diagnosed with colorectal cancer at the age of 48?
Yeah, then he will fall in the moderate risk group.
Yeah.
Then he will need a colonoscopy at the age of 50.
50? Are you sure? 50 or 55?
I'm sorry, I need to
Yeah, that's fine.
Yeah.
I think you also confused me. So yeah, I think it's 50. Anyway, yeah, that's good. That's good. Okay. So, so from the history, and did you ask about tenesmus in the history?
Yes, this is also important. For example, tenesmus, any mucus that may signify a rectal tumor.
Yeah. And what is tenesmus?
Tenesmus is a symptoms that when there is for example, a mass or a tumor at the rectum, the patient will have a persistent feeling that he wants to defecate.
Yeah, good. Okay. So this patient has got a change in bowel habits for last 3 months. Bleeding per rectum, it is mostly bright red in color, and no history of weight loss. There is no significant past medical history, no significant past surgical history. Okay. Move on. Let's move on to the examination.
And in the physical examination, I will check for any pallor, and I will also feel for the abdomen for any abdominal mass. I will also do a detailed parietal examination, especially see if there is any prolapse hemorrhoid, any 4th degree hemorrhoid. And if the patient allows, I will do a digital examination, mainly feel for any mass, especially over the anus and the rectum, and also to see if like there is any blood in my glove. Yeah.
So on the what else are you going to do? So you did a rectal examination. You check pallor, abdominal examination. Anything else that you need to assess?
Yes, after the digital examination, if there are instruments available, I will also like to do a proctoscopy in a clinic.
Yeah.
But in my trust, there is no rigid sigmoidoscopy available in the clinic. So I think I will just be able to do a proctoscopy, just for check for any internal hemorrhoids.
Where do you work? Do you work in here?
I work in Nottingham. Yeah.
Nottingham. Okay. So what do you think? Okay. On examination, the patient is pale. Otherwise, rest of the examination is okay. Rectal examination is normal. What is your various differential diagnosis, and how are you going to manage this patient?
So if there is pain, I would worry about anal fissure. So I will also check if there is any anal skin tag or no. Okay, so then I think so I think the next step for the investigation is blood test, and I will also arrange a colonoscopy for the patient in view of the positive fit test. And blood test, I will mainly check for any anemia and also the baseline liver renal function test. And for the fit, because the fit is 20, is raised, I will arrange a colonoscopy for the patient to rule out colonic pathology.
And any other studies you want to do? The patient is anemic. Any other studies apart from the blood? So what other blood test you can do?
Yep. So if the patient is anemic, I will also check the iron profile for the patient. Yep.
And
LGD as well.
And can you tell me in the iron studies how you can diagnose a iron deficiency anemia? What are the things you will test?
I would check the TIBC and the iron profile, which include the TIBC and the iron.
Yeah.
I'm sorry, I'm not quite sure.
No, that's okay. That's okay. Okay. So the patient is extremely anxious. Is extremely anxious about colonoscopy. Can you consent him for colonoscopy?
Yep. I would tell the patient about the reason I arranged a colonoscopy for him is because the fit test is raised, and also he had raised change in the bowel habit. So I would tell him the indication, and then I will tell him the procedure. That means the patient needs to, he has to prepare with a low residue diet for 3 days. And then we will give him the bowel preparation to be taken 1 day before and also night before the procedure.
Okay.
And then I will also tell the patient about the procedure itself. Is the insertion of the scope from the anus. Hopefully can see these for the whole colon, see the cecum, and also see if there's any pathology. And most important, I will discuss with the patient about the risk. The most important risk I need to explain is perforation in 1 in 1,000. However, if there is any chance that I need to take the polyps or a biopsy, then there will be a risk of perforation and bleeding. And I will also tell, apart from the procedure risk, I will also tell the patient about the sedation risk. If the patient needs the sedation, there will be chance of light respiratory depression. If I need to give him buscopan, there's chance of light tachycardia. And then I will also give him the options of not doing anything.
Yeah, very good.
Yeah, but then I will be worried, and I would encourage him to have the colonoscopy.
Yeah. So because you have explained so many risks about cardiac and everything, he is now become more anxious now, and he is asking you, is there anything else that can be done for colonoscopy?
So apart from colonoscopy, another options will be a CT colonoscopy.
Yeah.
And which is also sensitive and specific. However, is not specific. For example, in detecting, it's not sensitive in detecting small polyps, like less than 1 cm.
Yeah.
And I will explain to him about the procedure. For example, the patient still needs to take their bowel preparation. And then during the procedure, a rectal tube will be inserted and with gas insufflation, and the patient will have the CT scan afterwards.
Yeah.
And it is a less invasive procedure.
No worry. Okay, so the patient finally agrees to goes for a colonoscopy. I will try to bring up the picture, but meanwhile, can you just tell me what is colorectal screening program and how does it work?
In the NHS, the colonoscopy screening program is starts from the age of 60 to 74. Is the use of a fit test, which was checked 2 yearly for the patient, and a fit of more than 10 with symptomatic will be able to refer to the 2-week wait pathway for further investigation.
Fit of more than 10 and symptomatic. Or
Symptomatic, yeah.
What if it is fit is more than 10 and asymptomatic?
If the patient is in this case, if the patient is also symptomatic but the reading is less than 10, the GP can also refer.
What if the fit is more than 10 but patient does not have any symptoms?
Sorry, I'm not quite sure.
What is the meaning of screening?
Screening is to try to use a test to detect the disease in a group of asymptomatic patients.
Yes, exactly. So the fact that so fit test is a screening process. Yeah. So you do a fit test, and if the fit is high, you send the patient. Yeah.
Okay.
What if the patients are symptomatic, but the fit is less than 10? What do you do with this patient?
It can be referred to us as a urgent pathway.
Yes. Yeah. Okay. So do you do colonoscopy? Yeah. Okay. So you are doing the colonoscopy, and in the room next to you, a nurse endoscopist is doing colonoscopy on your patient, and she sees this. This is in the sigmoid colon. She is sort of caught by surprise, and she doesn't know how to proceed much further. So she has called you into a room to guide her. Just tell me what are the things you want to assess in this scope, and what information you would need to get.
So it is in the sigmoid colon. I can see a circumferential ulcerative growth with a pinhole lumen. So I think the scope cannot pass through it. It's a stenotic tumor, to be honest. And then I will actually check the distance of this tumor from the anal verge, and also I will check the NBI, the narrowband imaging, to see the capillary pattern. I would suspect it is a cancer, and I would take more than 6 biopsy and also do a TAC2 distal to the tumor. And after that, I will also see from the anus along this tumor to see if there is any other lesion. And after the scope, I will arrange a CT colonoscopy for this patient as complete the staging, CT, chest, abdomen, and pelvis for the patient. And I will also bring the patient to a quiet room, preferably with a cancer nurse with me and a relative to explain the findings.
Okay, that's good. So just tell me again, in terms of the polyp, so you're going to assess with the narrowband imaging. You're going to take 6 polyp, 6 biopsy, narrowband imaging, and what else?
TAC2.
Tattoo, yeah. Anything else? Why do you want to do narrowband?
Narrowband imaging.
Yeah, why do you want to?
Because I want to see the capillary pattern, the seno capillary pattern. I think it will be grade type 3, and also if possible, I can see the pits pattern as well.
Yeah, so
the pseudo pits pattern, I think will be 5.
Yeah, so you want to assess and then you want to assess the Paris classification. You want to assess the pit pattern. You want to assess any ulcerations, any lifting. Does it lift or not? Okay. So let's say that the procedure it is not completely obstructing tumor, and she was able to do the procedure completely. There is no other polyps up front. What do you this looks like a large sessile, partly pedunculated polyp, which is about 4 to 6 centimeters. What do you think you can do? Do you want to do anything else for this polyp? If it looks benign?
If it is benign.
If it looks benign, obviously we don't know yet because we're not.
Okay.
Yeah.
If the staging doesn't show anything, I will put this case in the SPECT MDT for further discussion. But I believe polyp of such a size is very it's difficult for a complete EMR with adequate margin or ESD. So I think the options for this patient, if I think he is surgically fit, is a lap sigmoidectomy plus or minus open.
Okay. What if you discuss this case in the MDT, and the MDT has done, so there is an excellent gastroenterologist who told, okay, I can do this EMR. So they've done an EMR, and the histology is back. what are the important points you want to know from the histology?
I would like to see whether it is a cancer or not, or it's just a tubular villus adenoma. I would like to see if it is a cancer. I would like to see the margin and the lymphovascular permeation, and the grading and the differentiation. And because if there is lymphovascular permeation, if it is a cancer, then a margin is not clear, then the patient needs to have the definitive surgery.
Yeah, okay, that's fine. We'll stop it here. I mean, yeah, okay. I think you did quite well. Only thing is, like, as a feedback, you need some practice in terms of you should be able to illustrate the history. Generally, you should not more than 1.5 to 2 minutes. Yeah, try to. But your history taking was excellent. You mentioned everything, and the colonoscopy consent was good. Sometimes they expect you to say that you would assess the lymph nodes, lymph node examination, the groin nodes, which is very important. The other thing in the history taking is you should always mention that you are going to assess the patient nutritionally. So you want to, so how will you assess the patient? How can you do that? Nutritional.
Can be clinically, biochemically, and
How do you do practically?
practically we'll see the BMI.
Yeah,
and
so
also muscle wasting.
Yeah. You can always say that I'm going to assess with a must tool. So read about the must tool. Yeah.
Yes.
It is quite important to mention all these things. Okay, must tool and this thing. So that they are aware that you're assessing the nutritional assessment and everything. And otherwise, you did quite well with the polyps and the histology. You just need to. There is a excellent paper from ACP GPI about malignant polyp, which has given the typical things that you need to assess macroscopically, things you need to assess microscopically. You need to, if you make a table, it's just 1, 2, 3, 4, 5, 6 points, and this thing. Otherwise, you do quite well. Okay, no problem.
Thank you.
Ravindra?
Yeah, just two queries. You were insisting on DRE. What next, Mosnis? Is it the sphincter integrity we have to mention that time?
So the digital rectal examination, it is very important to know what case it is. Okay, so if it is a case of pelvic floor rectal prolapse, fecal incontinence, and things like that, then you would need to be more detailed about digital rectal examination. You need to almost explain the digital rectal examination for at least 1.5 to 2 minutes.
Colorectal case.
In colorectal case, it is always important to assess the sphincters, because that information will definitely help in management of the case. If the patient sphincter is very loose and things like that, then you are never going to join him. So that it is quite important to assess the sphincters. So you can say that you are going to assess the resting tone and the squeeze of the sphincters while I do the distal rectal examination, and then you can assess this thing. But but you don't have to, if it's a colorectal cancer or things like that, you don't have to go in detail about DRE. You just need to, because time is your enemy. You need to try and see. If they want something, they'll again, okay, what else you can do for the this thing DRE? Then you explain DRE and this thing like that. Yeah. Okay. And Ravindra, one more feedback is that you should always try to involve your colleagues whenever there is a complex case. Okay? Pancreas and all those things. So this patient, pancreatitis, you should say, I will involve the HPB. I'll have a discussion with the HPB, what to do, and all those things. Yeah, in your case. So have a very low threshold in taking help from your colleagues and okay. Anyone else who wants to do Viva?
Just a quick question before the next Viva. Is it 50 or 55 for the middle risk? I think it's.
Oh, I need to see the guidelines. I'll see the guidelines. It's in the it's in the BSG guidelines. Yeah.
All right.
BSG hereditary colorectal cancer cancer guidelines is there. It is a huge paper. It's about 80 pages, but you don't have to read 80 pages. There is a table. You just have to read the table, and you categorize the risk into average, moderate, and high. That's all. There's no mild. Its average is the patient is equal to the rest of the population, moderate and high. So this thing based on this thing.
Just a quick thing. I've just checked the BSG is 55 for moderate risk.
Thank you. Yeah, 55. Yeah, that's what I thought 55, but Amy told 50 so confidently, so I was prepare this thing. Yeah, that's okay. Yeah. Okay. Yeah. Who? Anyone else wants to do?
Yeah.
Yeah. Ahmed. Let's see what I've got. Okay. Okay, Ahmed. So you are in the colorectal clinic. You're seeing a 65-year-old gentleman. The patient has got his main referral is for change in bowel habits and bleeding per rectum. He's got a fit of 50. Okay, you've taken the history, and you're doing the examination, and you're doing a PR. On PR, you're able to feel a mass in the posterior wall of the rectum. Take it from here. What are you going to do?
Okay, so after they taken the history taken from the patient, I want to double check that he has any family history of any bowel cancer in any of the family members, and I will ask for any family history of inflammatory bowel disease as well.
Okay.
And on peer rectal examination, I would just want to check the tumor. As you mentioned, it's in the posterior wall of the rectum. I want to check whether it's like going an annular constriction or not, and if I can be able to check of any perirectal lymph node in the along the side of the tumor as well. And also, I will take a history taken from the patient about
lymph nodes. How will you assess the perirectal lymph node on PR?
Sometimes I can feel it in the mucosa, just under the mucosa. I can feel it just close to the tumor.
Okay.
And also, I want to get back to the history taking with the patient about if there any fecal incontinence for flatus or for stools, and if it's happening, for how long have you had it? And also, I want to check the performance status of the patient and how long he can walk and about his functional daily activities.
Why do you want what is the relevance of the history of fecal incontinence in this patient?
So I would just want to check whether there is because if he got a fecal incontinence, that probably means that the tumor is invading into the sphincters, and it could be a T4 tumor. I want to exclude clinically to try to stage the tumor. Was it a T4 or just the early tumor T1 or T2?
Okay.
And I would then complete my examination. I want to examine his groin to check for any lymphadenopathy. Also, I would like to examine his abdomen and to feel for any abdominal masses, just to exclude the risk of any synchronous tumors, bowel tumors.
Okay.
And then I will discuss the patient about the finding. Sometimes I can do.
What else do you do in PR? So imagine the patient is there on the bed. You're done a PR. You're feeling the mass. So as I said, you are feeling the mass, the growth, and you told about the lymph nodes. Anything else? What else you need to assess?
I would just want to assess the external, inspect the inner canal from outside, just to inspect for any ingress of the tumor distally, and to check also if there is like any invasion which going to the sphincters or going to the outside in case of it's a fungating mass.
Okay.
And then do
you want to assess the tone of the sphincters?
Yeah, I would just by rectum ask the patient to squeeze over my finger to assess the tone of the sphincter as well, just to assess the invasion if there is further invasion. And then I can do, if the tumor is not that constricting, I may offer the patient to do a flexible rigid sigmoidoscopy, and just to know where is the top end of the tumor, and also I may be able to measure the distal end of the tumor down to the anal verge, just to know how distance is far from. And then, as mentioned, I would just examine abdominal examination to rule out any synchronous bowel tumors which I could feel.
So imagine you have done a rigid sigmoidoscopy and you are seeing the tumor. Do you want to take a biopsy now?
I wouldn't say I wouldn't take the biopsy in the clinic. So I would just arrange for an as an urgent colonoscopy, just to try to take the biopsy from the rectum and also to examine the whole colon up to the ileocecal valve with ileocecal intubation to rule out any synchronous bowel tumor. So also I will just go through the medical history of the patient. Sorry, I got a cold. A second. Yeah, I will go through the medical history of the patient, ask about his performance status, as I mentioned, any previous associated past medical history, if any medication is the patient is taking on, and check for the history of any blood thinning medications. Then I will discuss the patient. I will go through with him that the next step, I'm suspecting a tumor, which is probably could be a malignant tumor in view of his positive fit test. So I will just tell him that we're going to do an urgent colonoscopy, which is a camera test. I'll discuss the risk of the procedure, and I will offer him the option if whether he can have it awake or can have it under sedation. And if he's happy to have it without sedation, that should be okay. If not, I will consider that and put the request on. I will just explain the procedure with him and the risk of complications, which probably they're in the form of bleeding or perforation, or assure him about the incidence of the perforation. It could be 1 in 1,000, but still it can be happened. And also I will, as it's a tumor in the rectum, I would like to order as well an MRI scan of the pelvis, just to know the extension of the tumor, and also to assess the circumferential resection margin and to look for extramural vascular invasion. And then I will order as well a CT thorax abdominal pelvis for staging of the disease. And then I will like to, because it's a rectal tumor, I would like to refer the patient for colorectal MDT discussion, which should evolve after getting the biopsy, after having the colonoscopy and biopsy, to detect what stage is the tumor, starting from T1 to T4, just to know whether we need like to go straight away. If it's T1 tumor, we can go straight away to surgery. And if it's T4, probably we may need a new adjuvant therapy before considering the surgery.
Okay, so in the clinic, you requested a colonoscopy, an MRI, a CT chest abdo pelvis. Yeah. Which one do you want to do first?
The first one is to do is a colonoscopy to get a tissue diagnosis and to know what is the nature of the tumor.
Okay, and then you want to do MRI and this thing. Yeah.
And then MRI and CT scan. Yeah.
So he is 65 years. He has had a colonoscopy, which is showing a tumor in the rectosigmoid region. It is about 15 centimeters from the anal verge.
Yeah.
And they have taken a biopsy. It has come back as adenocarcinoma of the rectum. It's 15 centimeters from the anal verge. Unfortunately, patient has not had staging. He has had some family issue, so he has gone out of the country, and now it has been 6 months now. He has come back. The patient has come back to A&E, and you are the on-call consultant, and the patient has come back to A&E with abdominal pain and abdominal distension. How are you going to approach the patient?
So the patient is known to have a previous tumor, which is not fully investigated. I would assess the patient according to the CRISP protocol, create a critical ill patient, check for airway, breathing, circulation, disability exposure. I'll make sure that 2 large bore canula has been put, fluid resuscitation has been started. I will ask the nurse to do his routine blood if not done. And I will start by examining the patient, taking history. I will take history when the last time bowels was opened, and I will check if there is any vomiting or not. I will examine his abdomen and just feel for the distension, and it would probably do percussion to check it's like to give an idea, like it's a gaseous distension or it's a bowel obstruction, and it depends what last time open his bowel and if there's any vomiting and on the bloods. Because maybe querying, it could be like the tumor was there is now obstructing, so it could be obstructing. And also I would like to check the UNEs of the patient. If they are in good, EGFR is fine, I will go ahead with a CT scan of the pelvis with IV contrast just to assess. And also I would like to do perirectal examination. So perirectal examination, I can feel the tumor. It's like it's circumferentially obstructing, whether I can pass my finger or not.
Yeah. Okay. Okay. On examination of the abdomen, what are the important signs you are assessing that will help you in saying, okay, this patient might need to go to theater?
So the important sign I want to look at is the presence of peritonism, like just to exclude, because tumor is at the rectosigmoid junction, may have the possibility it could be perforated. Also, I want to state if there is massive distension, that means the tumor is obstructing there.
Okay.
And it depends whether, and also I would check whether, like, if there is a shifting dullness on examination on percussion, just to check if there is an ascites. So probably could be an advanced, because it's now 6 months, so there's a possibility it could be metastasized to the liver.
Anything else on examination?
I would like to do a groin examination just to
Yeah.
check for any associated lymphadenopathy.
Anything else in abdominal examination?
I would just want to feel for the liver just to rule out any hepatomegaly or
That's
metastasis.
fine, don't worry.
Yes.
It's okay. So he has had a scan.
Yeah.
I'm just putting up the scan now. Okay, just read the scan.
So what I can see from the scan, there is a massive fecal loading across the whole colon.
Yeah.
Across the right side of the colon, and I can see the tumor there down in the rectum, which is like taking the on one side.
Read this. You should read the scan. You should start with the basic.
Yeah.
You'd like to confirm the name, number, and this thing that the scan belongs to the patient.
Yeah.
And this is a whatever scan of the abdomen, what view it
Yeah.
is, and what you are reading first, and what you are going to read first.
Yeah. Okay. So the first one on the left. So it is an X-ray of the X-ray. Is it X-ray? This one?
Is it X-ray? Is it called?
Yes, X-ray. Yeah, and I can see like a coffee bean sign, which sounds like, is it a coffee bean? Like there's a no.
Just, even if you don't tell the sign, it doesn't mean. But just tell what you are seeing. What is standing out on the X-ray? There's no. Don't worry about the sign.
Yeah, so that's the distended bowel loop.
Exactly.
Yeah, this is distended bowel loop, but it's
Or
like
small bowel loop, large
yeah,
bowel loop.
I think that's a small bowel loop because like, is it? Oh,
This one?
no, it's no, that's a colon. I would say it sounds to me like a volvulus.
Is it small bowel or large bowel? This one.
Doctor,
I think that's a large bowel. It's a volvulus. It's that a volvulus.
No, it's the same patient. It's fine.
Okay.
It's not a volvulus. Okay. What is the CT? What can you see in this in the CT image, and what CT is it?
So
one on the
that's yeah. So that's one is like it's a coronal view of a CT scan of the abdomen pelvis,
Yeah.
and I can see there is a fecal loading in the colon, and I can see the tumor down there in the rectum on the left upper side of the rectum.
Okay.
And it's not completely obstructing. That what looks to me.
Okay.
Yeah, and I can see some feces down in the rectum.
Okay, that's very good. Okay, so what do you want to do for this patient?
So I think I'm just gonna get the image again, please.
Yeah.
It's the X-ray because it's a large bowel, but it's I think
it is large bowel.
Yeah.
It is a large bowel.
Yeah, it is volvulus, I think.
No, it's not volvulus. It's
a large bowel. It's a bowel obstruction. I think the patient is obstructing, is an obstruction.
Yeah.
Yeah, so what I would say, I would admit the patient. I would like to manage the patient starting with for bowel obstruction and give IV fluids, give nil by mouth, and put an NG tube down in. And the patient, I think he got I want to see the CT scan again to check the ileocecal valve, was it competent or not. And it depends on the NG tube, whether a feculent material is going to come or just intestinal. Because if the patient got a competent ileocecal valve, that means it's maybe there's a high risk for perforation, which he may need an urgent operation. But yeah.
Okay, so this patient did not had a competent ileocecal valve. It was a large bowel dilated, and you discussed the scan. It's a rectosigmoid tumor, which is causing the obstruction in this gentleman. So he's 65 years, performance status of 2. He's 65. He had a cardiac history of 6 months or 5 months back. He had an MI. He's on aspirin and clopidogrel at the moment. He does not have any stenting. So what are you going to manage?
So the next step is to do, because the patient hasn't completed his staging investigation and he's a high risk patient and he's having a recent MRI, he's in blood thinner. So I would like to admit the patient and discuss with the interventional radiologist or endoscopist for possibility of stenting, because it's at the rectosigmoid junction, should be feasible to stenting. And after then, if that was successful, I would then do a staging investigation in the form of MRI of the pelvis and do a CT thorax as abdomen pelvis again.
Is this what you do in your practice routinely?
Yeah, yeah.
Stenting. What is the
If
problem with
it's
stenting? What is the problem with stenting?
so what is the sorry,
what is the problem with stenting?
The problem with stenting with the tumor is the commonest complication. It can migrate and can perforate.
Okay.
But if they can be able to put it, it should be a good option for him in view of his comorbidities because he had a recent MI, and also it will allow for further staging of the disease. Like if this.
What is the main advantage of stenting? What is the main advantage of stenting?
The main advantage of stenting is to allow for further staging of the patient to avoid giving him an emergent operation and giving him a stoma. And also can give the advantage in this scenario. The main advantage is like also to treat the bowel obstruction because he's not perforated, not peritonitic, and also it will give the time for staging and possibility if he can have a neoadjuvant in case the CT thorax abdo-pelvis didn't show any metastasis. So we can have a neoadjuvant chemoradio and then can be planned for surgery as a semi-elective.
So this is a rectosigmoid tumor. Okay, this is a rectosigmoid tumor.
Yeah.
It is not a rectal cancer. It's a rectosigmoid tumor. So you can the role of neoadjuvant and all those things. It is not definite. It is a rectosigmoid, or you can treat as a sigmoid cancer. Yeah, but I agree. Do you think how likelihood is this patient is going to have a primary anastomosis without an ileostomy or a primary anastomosis? Taking into account the size of the tumor, he had a recent MI within age of 5 months, and almost a completely obstructing cancer. What is the likelihood that he may have a primary anastomosis?
So that's mean if the stenting is failed.
No, in general. So in general, so you
in an elective setting.
Yeah, in an elective setting.
So in an elective setting, so whether to determine that we will do primary anastomosis or endostoma, it depends on the performance status of the patient. So in this patient, the performance status is 2. He got a recent MI and he's on a blood thinner. So I would discuss with the patient because and it depends on the site of the tumor. Here it sounds like the tumor is above the peritoneal reflection. So in general, we can do primary anastomosis without defunctioning. But because if the patient is high risk, so I wouldn't put him to sleep in a couple of times. So I will discuss with the patient the high risk of the patient. I'll prefer to discuss with the patient for doing like a Hartmann procedure and giving him an endostoma, because if we do the primary anastomosis, it will be a risk of a leak, which is the tumor is at the rectosigmoid junction. It could be rising up from 5% up to 20% chance there is a leak, which will need further surgery, and that put him to double stress for a surgery, known to have a recent MI. So I would rather discuss with the patient, and I will take an anesthetist opinion, and probably I will end up with doing like a Hartmann procedure.
Yeah, I completely agree with you, because you want to be a safe surgeon. Okay. So why don't you do the Hartmanns now instead of putting a stent and then doing a Hartmann? So why don't you do a Hartmanns now?
So to do a Hartmann now, but I have to stage first. I want to stage the tumor first. I want to do CT thorax abdomen first and to know what the result is, metastasized or not.
How does it going to change your management? You already got a CT. There's an obstructing rectosigmoid cancer.
Okay.
And it's an incompetent ileocecal valve. You already done a CT abdomen. You want to do a CT chest, is it?
Yeah.
How does it going to change the management?
So because if the tumor is metastasized, so I would then defunction the patient, and then probably I'll palliate the patient. I will defunction with probably a loop ileostomy. I will defunction the patient and then palliate if there is a metastasis, lung or liver metastasis.
That's fine, Albert. Don't worry. Okay. Yeah, that's fine. We'll stop the scenario. Okay. So, few things, because you are trying to open a new discussion with, and then the discussion might have gone into, okay, the patient has got a single lung met, the patient has got a 2 lung met, patient has got bilateral lung met. What are you going to do? How do you know whether it's non-treatable and all those things? So overall, your risk taking was excellent. Your knowledge is very good. my advice would be to try and slow down a little bit in terms. And one of the, I would almost say it's a mistake. So just imagine you are just in the clinic, and I asked you what are the next steps. So all you need to do is you should say, I would get a, as you rightly said, a colonoscopy, a CT scan for distant mets, and then MRI for local staging. So that's all you should say. You should not say, okay, if it is T1, I would go for early cancer. If it is T4, if it's a neoadjuvant, if it's 2, 3, because you don't know, you don't have the diagnosis in front of you. Okay, and don't you should avoid talking hypothetical situations, because the problem is you may think that scenario is rectal cancer, but that scenario might be completely different. Completely different, saying that okay, the patient has already gone off, and now he has come back, and he has come back with some breathless or PE and something else. You never know what the scenario is. Okay, so this thing, this confusion, one of the reasons why I discussed obstructing rectosigmoid cancer is there is no right answer for this. Okay, so the way to approach is you need to offer the patient all the things. Okay, the main problem of doing of stent is that if it is a center where you don't do stent routinely, or if it is this thing, if it is a T3 tumor and if you cause perforation, you are making the tumor almost incurable. Yeah, it is a T4 incurable cancer then. So that is the main risk. So if the stent goes well, it is well and good, but you need to, how are going to address if you perforate the tumor? So you are literally converting a curable to an incurable disease. Okay, so that is why you need to offer. So this is where a shared decision comes in place. Okay, you should say that I would offer the options available to me right now would be either to perform stenting or to do a Hartmann's resection, which both are right. And then you can explain the risk and benefit. And I would in this thing, then you can say, if our own center is not doing, you can always say, well, I can discuss, and I will refer the patient to a center where they do stenting regularly, because I think this thing. So you need to express concern with regard to both, but the main thing you need to know is what is the aim of doing the stenting. And you are 100% right. One of the aim of doing a stent is to reduce the stoma, but even after in the elective case also, say if it is if you're not going to do joint, and then the overall benefit of the stoma is not that much. The other thing is this scenario, it is an obstructing cancer. Okay, so there was no need for you to open up the overall discussion about the neoadjuvant and things like that, because you may think, okay, you may think you have discussed well about the neoadjuvant and adjuvant and this thing, but the scenario is not about that.
Yeah, because it's rectosigmoid, so we don't know whether it's up or down.
So that is a whole other discussion. Of course, with the new Foxtrot study and all those things, even with rectosigmoid, you can give all this radiotherapies. But that's that's a different scenario.
Different scenario. Yeah.
This is not this scenario is not about that. Okay, so you may think you had a good discussion with the examiner, but you have not gained any marks there.
Yeah.
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 But otherwise you did very well. Don't worry. Okay. This thing.
Okay.
But this is we see very common thing where you want to arrive. You want to tell the whole management in the first situation only. So this is something you need to, because imagine there is no hypothetical situation. Imagine there is a patient. And this thing, again, it is very common. Oh, if the MRI scan shows this one, I want to do this, you want to do this. No, just want to do MRI scan. It depends on the staging and things like that. Okay.
Thank you.
Yeah,
Thanks, Akshay.
Yeah.
Thank you.
Okay, we can do. I think Ravindra does hand up. The abdominal examination. What I was pressing you was on when you're examining the patient in the A&E. You should say, if you say that if the patient is having tenderness in the right side of the abdomen, a cecal tenderness, that means you're almost, the cecum is almost at a risk of perforation because of the full-blown obstruction.
Yeah.
And then
Yeah.
whatever the scan show, then the patient would need a whatever subprotocolum or this thing. If there's, so that's what I was trying to. This thing.
Yeah.
Ravindra, are you there?
Yeah, I'm there.
You were asking something, or?
Yeah, regarding the same thing, it's like whether we should take this scenario to do the closed loop obstruction and concentrate more on a cecal perforation, something like that. What you insist,
So,
or anything else we have to elaborate?
No. That's also on the examination. I can say I would be concerned about if there is any tenderness in the right side. Then I would be worried about a cecal perforation, things like that. Otherwise, you would do the scan and then you take it a call. Yeah. Okay. Anyone else? We can do one more scenario if anyone wants to say. Or we can just, if anyone wants to ask anything, we can just discuss for next 10 minutes.
So with regard to the scenario, I had it actually.
Yeah.
So when you said like the patient, what's if he got a metastasis, like a lung metastasis, or so what shall be the next step? So is it like a defunctioning, or will still go?
No, see, the patient has got a obstructing. So try to make the scenarios as simple as possible, and
Okay.
you are try to addressing what is best for that patient at that particular time. Okay, whether the patient has got a single lung med, double lung med. Right now, patient has got a full-blown bowel obstruction with obstructing rectosigmoid cancer. So what you are to assess is the patient performance status. A diversion colostomy also requires a general anesthesia, putting the patient to sleep, and even a Hartmann's also does the same. If it is a obstructing rectal cancer way down, yes, of course. If then the role of just a diversion colostomy is much more there. But if it's a rectosigmoid, as long as you are happy with the performance status of the patient, you still go and do a Hartmann. You can still go and do a Hartmann's resection. I don't see any this thing, whether it's a single lung met or double lung met.
Yeah. Okay.
Yeah.
Thanks.
Atriya?
Am I audible?
Yeah.
No, just regarding the discussion, there was one question you had asked. If you have a
sorry.
sigmoid lesion. Am I clear?
Sorry, no. Can you repeat?
No, you had asked regarding which will be the first investigation to be done, whether you go for a colonoscopy first or would you go for a radiological investigation when taking a biopsy. So my question is, would you always go for a colonoscopy first, or when you take a biopsy, you alter the cancer
Yeah.
That is the question.
Yeah. So generally, especially in UK, as we don't do any procedures in outpatient. Outpatient setting is not ideal, or to do even sometimes banding also you can do, because there is a very less thing. And biopsy, though, you never do biopsy and all those things in the outpatient setting. So the first test would always be obviously colonoscopy, and then you can always address, and then you can do the staging and for local setting, and you can mention both MRI and CT. But the first step should always be colonoscopy and trying to get a biopsy. But no one does any biopsy in the clinic. It's almost impossible. Yeah. Uh, Amar?
Yeah, just one question. I'm not sure about my knowledge, but my understanding
It's okay.
of liver metastasis, if it's liver metastasis, it's advisable to go for Hartmann rather than putting a stent because Avastin affecting the wound healing. So you will not be able to do the operation later after a new adjuvant.
Eh,
I'm not quite sure about my knowledge, but that's my understanding from part
No,
A.
I understand. I think, I think that's a fairly good point. To be frank, I'm not entirely sure about what's the answer. But again, this patient did not have any liver met and things like that.
Yeah.
So I'm not. I'm sort of getting what you're asking, but I need to look into it. Yeah.
Yeah.
But
And can I just remind the delegates?
Yeah.
Because we all have kids. So would you mind, guys, if you keep your screens mute if you are not participating, because this will affect, because we will hear you actually from the other screens, and then it got like an echo sounds, and then
Yeah.
we'll not be able to hear that.
Yeah, I agree. But in general, colorectal liver met, it is one of the most complex scenario in the exam, which we do cover it in our course. But again, there is no straight answer. You try and do what is best in the for the patient and things like that. Yeah. Yeah, Salim.
Yeah. At what stage should we mention that we should discuss the case in MDT or multidisciplinary meeting?
Oh yeah.
Like the last scenario,
As soon as
all
possible.
through.
As soon as possible. As soon as when you say so, the process would be history, examination, investigation, MDT. Usually.
I think that is important. Yeah.
Yeah. So you obviously you try and take all the history and staging, and then you take the patient to MDT before making any management plan. That's what usually the process is. Yeah.
And I should mention the options that will be discussed. I mean, in MDT, or I will just leave it there.
Oh no! You should always continue. You should always the one mistake everyone gets irritated is ending the sentence with the referral to MDT. You should always complete the sentence that I would refer the patient to MDT. The most probable plan for this patient would be whatever it is. Yeah, you should try and come with a plan. Yeah.
आपने नहीं छेड़ना इसको.
Yeah.
That's great. Thank you.
Yeah. Agib?
Hello, hi.
Hi.
Yeah, I have no question. Just I found nobody want to take the case. I'm happy to take a new case if.
Oh, okay. Yeah, you can. I can do it. Can you switch on the camera?
Yeah, just a second. Hello.
Hello, Agib. How are you?
Hi, how are you?
Okay.
Famous.
Okay, let's start. So we'll discuss a 5-minute scenario. Okay. So you are in A&E. Your registrar is calling you because he has seen a 62-year-old gentleman who has been having severe parectal bleeding, and he has been bleeding for last 2 days, and there is a small drop in the hemoglobin as well. How are you going to assess the patient?
Yes. I'll go to see the patient, and the first thing I want to see if the patient is stable or not. This will be based on the shock index by checking the patient vital signs, the systolic blood pressure, and the heart rate. and I will start resuscitation of the patient by applying 2 whiteboard cannula and take blood for patient for routine blood and blood for a cross match of 4 units of blood, and meanwhile I'll start IV fluid and take quick history for the patient for if he had any comorbidities, if he had previous attack of similar bleeding per rectum, and what was the diagnosis, and if he had colonoscopy before, and when was that, or gastroscopy before, and if he's taking any blood thinning medication, and what is the indication, and his performance status, and then I will check the patient routine VBG for hemoglobin and for lactate, and check his other vital, other bloods, renal function test and coagulation profile, and according to his hemoglobin and resuscitation status, we may proceed for transfusion, and according to CHOC index, then we'll proceed for further. After
Okay, so this is a 62-year-old gentleman. He is known to have diverticular disease, and he has been having parectal bleed for the last 2 days. He has got a history of AF, so he is on apexaban, and his performance status is 2. He had a last colonoscopy done 8 years back, which shows diverticular disease.
Yes. I forget to ask from the history if he had any weight loss or any abdominal pain or any recent change of bowel habit, which is the constitution symptoms for rectal cancer. Then
He's been having some occasional change in bowel habits, but otherwise there is no weight loss or anything like that.
Yeah, and I will proceed by examination for the patient after the Muse score and vital signs. I'll check if he's pale or no, or jaundice, and examine the neck for left adenopathy.
Okay,
and the
so
abdomen.
you have examined the patient, and the hemoglobin is right now 90. It's previously he had a hemoglobin of 1 to 120. His pulse rate is 100. His blood pressure is normal. His rest of the observations are normal. Yes. On parectal examination, there is just a staining of your finger with blood.
Yes, the patient looks reasonably stable. I will proceed by do for the patient CT angio to see if he had any active bleeding.
Why do you want to do CT angio?
Just to see if he had any active bleeding for the site of the bleeding.
What is the indication to do CT angio?
The indication is if the patient is unstable.
Yeah.
To see the sort of the bleeding.
Is this patient unstable?
He's tachycardic with the pulse 100. But
yeah. But blood pressure is normal. Observations are normal. Its only thing is tachycardia of 100.
Yes. I will calculate then also the Auckland score for the patient to see if his Auckland score is 8 or above. I will admit the patient for observation, and I will book the patient for colonoscopy in the next available list.
So do you want to do CT angio or not?
I want to do CT angio because his pulse rate is 100 and it may catch the bleeding source.
No, it will not catch the bleeding source. Because what is the criteria for the CT angio to catch the bleeding source?
It needs to be more than 15 ml per minute.
Yeah. So, and if the patient is actively bleeding more than 15 mL per minute, you generally don't expect the blood pressure to be stable. Yeah.
Yes.
So, generally avoid a CT angio at this point of time. Okay.
Yes.
And you mentioned about Auckland score.
Yes.
This is a patient, 62 years old, diverticular disease, AF, apexaban. Okay.
Yes.
So, do you think, practically speaking, do you think you'd be able to send this patient home?
No, he will be admitted.
Exactly. So you'll admit the patient for observation, and then So as you rightly said, you plan for a colonoscopy or a sigmoidoscopy?
I will plan for colonoscopy, but without bowel prep, based on the bleeding as my bowel prep.
Okay, that's fine. the next, okay, so you come back the next day, you see the patient has had some more parietal bleed, and his hemoglobin is now 70.
Yes. If the patient had a history of cardiac disease or only atrial fibrillation. And,
AF, only atrial fibrillation.
yeah. If he's remained vitally stable, I will still continue with IV fluid, and I will proceed with the colonoscopy.
But the patient has dropped hemoglobin from
Yes.
90 to 70 now. He has got AF.
Yes.
What is the first line of investigation in a patient with a PR bleed with a drop in the hemoglobin?
The first line of investigation is CT angiography if the patient is unstable, but if
Yeah.
the patient is stable, we'll proceed for colonoscopy.
No. Okay. Okay. We'll stop. We'll stop here again. Okay.
Okay.
No. So if you need to read about the BST guidelines about the parietal bleed. There is a clear protocol about how you manage it. Generally, any patient, even with a PR bleed, once there is a drop in the hemoglobin, you should always get a OGD first rather than a colonoscopy. You should always rule out the upper GI bleed, and then it goes to this thing. And it is usually then a flexible sigmoidoscopy. Colonoscopy is extremely difficult. You cannot give a bowel prep, and when you do a colonoscopy without bowel prep, it is fairly a negative test, and it is quite difficult to do as well. Okay,
Yes.
but it's okay. It's still, yeah. Just there's a BST guidelines. It will be helpful. Okay.
Okay.
Yeah. Atreya, your hand is been.
I think that was my mistake.
Okay, that's fine. Yeah. Who's next? Ahmad El Murray.
Hello. Yeah.
Hello.
Shall I consider in this patient, because he mentioned he bleeded again, shall I consider reversal of apixaban with aldexanate alpha or not?
Yeah.
Shall I consider to liaise with hematologist? Shall I just mention it?
Yeah. You should mention all
Yeah.
those things. Yeah. Mohammed.
Just a question. The question was PR bleed. There was no clarification whether it is bright red, dark, melena like.
Yeah.
So you no matter what it is, you're gonna go ahead with an OGD and flexible sigmoidoscopy to start with.
According to the BST guidelines, once there is a drop in the hemoglobin, the first line is an OGD always.
Okay.
Thanks. Okay, I think we are going to end the session. Thank you. It was excellent. I hope all of you I got some idea about it. Obviously, as you say, again, I want to say that it is Viva practice, Viva that is going to help you pass the exam. There is no need for you to sit in the room and study and things like that. Just try and see whatever case you see in your daily, in your own call and things like that. What you're going to do, what are the various options available for the patient. Again, it is working within the NHS. It is extremely difficult to give time, especially when you're on call and all those things. But for the next 3 months, especially for those giving the FEB exam, you have to be very, very selfish. Your aim and only aim is to pass the exam and not to give this exam again. That should be your aim. That requires quite a lot of dedication, trying to swap your own calls, trying to swap this thing, trying to get as much free time as possible. It doesn't matter. You may, after the exam, you may have to return all the favors that your colleagues have done, but it is still worth it if you're able to clear the exam. It is not an easy exam at all. Quite a lot of knowledge is required, but main thing is you're able to your communication matters a lot. Okay, yeah. Thank you. I hope we see a few of you in our course as well. Okay, thank you.
Thank you.
Yeah. Ahmad? Yeah.
Yes, actually, sorry, the last thing. So with regard to the Telegram group, to find you mentioned the guidelines, everything, you put it there. Is it still, it's not there now? Yeah.
Just a message on that group or this thing. I think someone will contact you.
Yeah, okay, fine.
Yeah.
Okay, thanks. Cheers.
Thank you.
Bye. Bye.
Yeah.